One and all. It is my proud privilege to welcome you all for the CME on intravenous fluids as a drug, perioperative decision making beyond the volumes. In the era of ever increasing information where the practice is mainly focused on clinical evidence based practice, we therefore put forward to you the Curiosity series, which is a series of CME to be conducted by the Department of Anaesthesiology, CURI Hospital, Chennai, on monthly basis throughout the year of 2026. Our primary focus is on increasing the awareness of perioperative medicine. To start with, I just pass on the mic to Dr. Avinash sir to give a welcome speech.
Thank you, Doctor. So, good afternoon, our respected dignitaries, esteemed faculty, and dear colleagues. I am Dr. Avinash, Senior Consultant, Department of Anesthesia, Critical Care and Pain Management. So, it's my great pleasure to welcome you all to our second Curiosity series on perioperative medicine, intravenous fluids as a drug, perioperative decision-making volumes at CURI Hospital, OMR, Chennai. CURI Hospital has established itself as a leading center for high-quality, patient-centered care along the OMR corridor. With its advanced infrastructure, state-of-the-art technology, that is a robotic system, and dedicated medical team, CURI Hospital continues to deliver excellence in healthcare. Over the years, CURI has grown into a trusted name offering advanced urology, uro-oncology, surgical gastro and robotic surgery, and nephrology care with a strong commitment to quality, safety, and compassion. Few months ago, we had celebrated the successful completion of 1,000+ robotic surgeries. I am proud and privileged to be a part of it. So this progress is guided by our visionary chairman, Dr. P.B. Sivaraman sir, and director Dr. Ananthakrishnan Sivaraman sir, whose leadership and commitment to innovation and academic growth have been instrumental in shaping CURI into a trusted healthcare institution. I warmly welcome Dr. Nagasamy sir, senior most anesthetist in our India and an astounding teacher for moderating this event. CURI endorses this series of perioperative medicine as CURI acknowledges that our population is getting older and the prevalence of lifestyle-related changes is increasing against the background of difficult socio-economic circumstances. So IV fluids as a drug was chosen for this CME as perioperative decision-making for fluid management is vital in many critical and emergency settings with varied patient clinical background. Hence, this involvement is a multidisciplinary role of anesthetists, intensivists, and surgeons as a key driver. This CME will provide valuable insights into how we can effectively implement these into our daily clinical practice. So now we have Dr. Satish Rajaselvam sir, Senior Consultant Anesthetist, will be revisiting Starlinks in 2026, followed by Dr. Jacinth, Senior Registrar, who will talk about the mercurial lactate. And finally, we have a very interesting problem-based learning discussion about the case of end-stage renal disease with CAD and severe LV dysfunction and polytrauma for fracture femur surgery by Dr. Naveen Gandhi, Junior Consultant Anesthetist. We are grateful to our management for this opportunity, and we are happy for our distinct speakers and participants for being a part of this academic program, and we are confident that today's session will be informative and enriching. Once again, I warmly welcome you all. Thank you.
Thank you for a warming welcome speech, sir. Now I call upon Dr. Satish sir, Senior Consultant, Department of Anaesthesiology, to guide us through this important subject and share his clinical expertise, academic contribution, and clear approach to translating evidence into practice. Over to you, sir.
is going to have a proportionate increase in the contraction of the cardiac myocyte. And Dr. Ernst Starling added to this hypothesis that by means of increasing the venous return, the cardiac myocytes go into lengthening, wherein they enhancedly contract, leading to an increase in stroke volume. They both combinedly formed a graph that is called as cardiac function curve, wherein the cardiac output is plotted against the right atrial pressure. The central curve that we see here is the most optimal curve. On the x-axis, we are seeing the right atrial pressure, and on the y-axis, we are seeing the cardiac output. Just like how the cardiac output becomes a function of the right atrial pressure, it is also affected by a few other factors such as afterload and heart rate. Whenever there is an increase in heart rate, afterload, or there is a decrease in contractility, the curve has a rightward and downward shift. And whenever there is an increase in contractility and decrease in afterload, the curve has a leftward shift and upward shift. So the cardiac function curve has at least 3 parameters that can determine its progress. Primarily, venous return, which is the preload, contractility, and the afterload. This is a graph demonstrating how venous return increases our cardiac output. But this is a venous return curve. I'll just momentarily go on to explain how the venous return curve is going to affect the cardiac output as well. Here on the x-axis, we are seeing the right atrial pressure. And on the y-axis, we are seeing the venous return. Mean systemic filling pressure is the stressed volume of the capacitance vessels, which are the venous vessels. The mean systemic filling pressure can be directly equated with any volume that is infused into the vasculature that is going to have a stressing effect on the vasculature, venous capacitance vessels, therein returning to the heart as venous return. So here on the x-axis, as you're seeing right atrial pressure, as the pressure decreases, the venous return to the heart increases. But at a certain point, the critical pressure below which any further decrease in the right atrial pressure is going to have a compressing effect on the great veins of the thorax, wherein limiting further increase in the venous return. So below the critical pressure, there is no further increase in venous return. So on the x-axis, we are seeing right atrial pressure. What we've done here is like we have superimposed the two graphs. The dotted lines are the venous return graphs, and the curved lines are the cardiac function curves. The point 1 that we see here is the point where the heart is not having adequate contractility. If we increase the venous return at this point, there is no effect on the cardiac output because the curve is on its plateau part. But if we have managed to increase the contractility of this point, we tend to increase the cardiac output. We travel to the point 3. But any further increase in contractility is not going to have any effect on the cardiac output because we directly travel to 0.4. That's primarily because we have breached the critical pressure. Any breaching of the critical pressure is not going to have any enhancing effect on the venous return. So from here on, our only option is going to increase the venous return. If we increase the venous return from 0.3, we travel to 0.4, 0.5. So our optimal functioning happens when our patient happens to be in this part of the curve, in the steep part of the curve. We have to find the balance between increasing venous return by means of giving fluids or increasing cardiac contractility. Afterload in any given day is going to have a detrimental effect on the cardiac output. So at any given point, the cardiac output can be primarily increased by 2 means, which is increasing the venous return or increasing the inotropy of the heart. And which maneuver we have to follow depends upon how the patient is going to respond based upon his physiological status. We'll go into detail of those things in a short while. I would like to bring forth one another hypothesis or principle proposed by Dr. Ernst Starling. This is insofar as what happens to the fluids in the peripheries of the body. In the peripheries, there are 2 forces acting in the vascular system. One is the hydrostatic pressure, the other is the oncotic pressure. Inside a given vessel, the hydrostatic pressure tends to push the fluid out into the interstitium, and inside the same vessel, the oncotic pressure is going to retain the fluid inside the vascular system. At any given point, these two pressures are acting in opposition, but at the arterial end, the hydrostatic pressure is managed well by the oncotic pressure. So there is slight excess in hydrostatic pressure, and there is movement of fluid from inside of the vessel to into the interstitium at the arterial ends. And at the venular end, because of a drop in the hydrostatic pressure and because of a relative excess of oncotic pressure in the interstitium, fluid moves back into the venules. So this is how the peripheral homeostasis is maintained as per Dr. Ernst Starling's original hypothesis. But the recent days, based on extensive evidences from various studies across the world and across timelines, it has been proposed that Dr. Ernst Starling's law might not be as simple. There might be another few other factors acting in place. Here comes something called as endothelial glycocalyx. Some of the concepts of endothelial glycocalyx goes against the concept of Dr. Starling's forces. The endothelium happens to be the largest organ in the body, unlike the skin that we used to think of. And endothelial glycocalyx plays a significant role in fluid homeostasis, modulation of inflammatory reactions, and adhesion of platelets and leukocytes. As per the conventional teaching, if there is going to be huge vasodilatation or blood loss, our initial fluid of resuscitation happens to be normal saline. But the downside of normal saline or any crystalloid was it has the tendency to go into the peripheries because of poor oncotic pressure. So the proposal was to use colloids to counteract the seepage of the crystalloids into the interstitium. So whenever there is necessity for us to act against tissue edema, we were taught to use colloids, be it starch, be it gelatin, or be it blood, or even albumin. But evidences across the world, from the last 15 years at least, have proved that the fluid of choice for resuscitation of septic patients is not colloid, not albumin, but balanced salt solutions. This is going primarily against what the Starling's principles say. Starling's principles say because of excess hydrostatic pressure and because of low oncotic pressure at the interstitium, the fluid seeps out into the interstitium. So based on that principle, the colloids have to be the fluids of choice for management of peripheral shock. But evidences over the last 15 years say that crystalloids behave well, particularly the balanced salt solutions behave well compared to the colloids. Why so? We bring in something called as the glycocalyx model. Here, what we see here is the endothelium, and this is the lumen of the vessel wall. Just beneath the endothelium, we see something called as the endothelial glycocalyx layer. This endothelial glycocalyx layer is made up of glycoproteins, which is osmotically very active. Primarily from Starling's hypothesis, this particular layer was not counted in. The recent reviewed Starling's principles bring into account this EGL, which they say has got enormous osmotic potential, and therein able to explain a lot of evidences that has been achieved over the last 15-20 years. They basically say that the intravascular volume is composed primarily of the endothelial glycocalyx layer, then the cell volume. Earlier, it used to be only the plasma volume and the interstitial space. So coming back to cardiac function, now that we've understood what is Frank Starling's law and how the Starling's laws have been evolved in the last 15-20 years, now we'll come back to the original question of cardiac function curve. So how do we find if the patient is going to respond to our fluid boluses? We know that only 50% of our patients respond to fluid boluses, and fluids are associated with harmful effects if they are not serving its purpose of increasing cardiac output. So the remaining 50% of the patients are going to have some sort of complications. And any increase in fluid load to the body beyond the increase in cardiac output is going to increase hydrostatic pressures and is going to lead to a lot of tissue edema, which is reflected as extravascular lung water. So how do we assess? We use certain parameters, which are primarily called as static parameters or dynamic parameters. Static parameters used to be of all many things, CVP and POP, central venous pressure and pulmonary artery occlusion pressure. We have known from the recent years that CVP and POP are poor markers of fluid responsiveness. Physiologically, they do not directly correlate with left atrial filling pressures, left ventricular filling pressures, and even otherwise, they do not reflect how the contractility capability of the ventricles are just by means of being continuous with the left atrial, left ventricular volumes. So we bring in something called as dynamic parameters. Dynamic parameters basically consist of two actions. One is we induce a change in the preload, and once the change in preload has happened, we use some modalities and measures to assess for changes in the cardiac output. By this, we are able to directly assess if the patient is going to respond to our fluid bolus or not. And by this, we are able to prevent any deleterious infusion of fluid into the patient. And this change in preload can be managed by using mechanisms that involve heart-lung interactions, or it can be done by infusing real fluids or virtual fluids into the patient. And we use some mechanisms and modalities to assess for changes in the cardiac function, which is the cardiac output. So let us assume that I have managed to elicit some sort of a change in the preload. Now I want to assess my cardiac output. How do I assess my cardiac output? Obviously, I have to use some instruments or my equipments. I can go directly into the central compartment, central vascular compartment, and look for cardiac output by placing a catheter that is as invasive as a pulmonary artery catheter. In fact, this is the gold standard for assessing cardiac outputs. But complications, and it requires great expertise to measure cardiac output in real time, which is not feasible in the present day. So we go for semi-invasive or non-invasive methods. Semi-invasive method is an arterial line where the arterial pressure is observed on a monitor, and the contour of this particular arterial wave is put through a software which gives us measurements about the cardiac output. They can be derived into pulse pressure variation or stroke volume variation. And we also use non-invasive modalities, which primarily involves the plethysmography, which again has to be put through some softwares to derive waveforms, wherein these waveforms can give us information about the cardiac output, and therein we can see for variations in the stroke volume and the pulse pressure. And of course, there is echocardiography. Echocardiography is a good technique to identify changes in the cardiac output, but it is like depends on the individual who's doing it, and it is giving real time, but it cannot be done at a continuous, long time, repeatable action, like in a stroke volume variation or a pulse pressure variation. So heart-lung interactions, with each positive pressure that is being delivered by the mechanical ventilator to the patient, there is a rise in the intrathoracic pressure, which leads to a drop in the right ventricular preload. Over the subsequent cardiac cycles, the left ventricular preload also comes down. At the same time, because of an increase in transformatory pressure, the left ventricular afterload comes down and the left ventricular preload goes up. And there is going to be an increase in left ventricular stroke volume. What happens after a few cardiac cycles is there is going to be an augmented cardiac output response during the act of inspiration, and there is going to be an augmented drop in cardiac output during the act of expiration. This particular change in cardiac output, cyclical change in cardiac output that is happening during inspiration and expiration, can be monitored real time by our monitors to give us information about indices such as stroke volume variation and pulse pressure variation. The physiology is very sound, and so is the evidences pertaining to their capability to assess the cardiac output. They have the highest evidence, but the downside is the environment in which this test has to be conducted is highly controlled. The patients have to be adequately, strongly mechanically ventilated. The heart has to be in sinus rhythm. There cannot be tachyarrhythmias. There cannot be tachycardias. The lung has to expand adequately. There has to be adequate tidal volume, and the lung has to have good compliance. And the respiratory rate, most importantly, has to be very normal. So these strict parameters that have to be fulfilled happens to be in a particular patient, not all the time. In fact, very few patients in any ICU in any given time fulfill these criteria. Studies have shown that only 3 or 4% of patients in an ICU fulfill these criteria for us to adequately interpret from stroke volume variation or pulse pressure variation. As I said, low heart rate, high respiratory rate, irregular heartbeats, low tidal volume, increased intra-abdominal pressure, open thorax, spontaneous breathing, they all go against the validity of using PPV or SVV to assess the changes in the cardiac output. So we naturally go for tests that can be used across the population with good amount of sensitivity and specificity. 2 tests have been found to fulfill these criteria. One is the passive lung raising test. The other is a mini fluid challenge. The passive lung raising test, wherein the patients initial semi-recumbent position is brought flat, the torso is made flat, and the legs are raised for about 30 to 45 degrees and maintained in this position for about 12 seconds. This pushes the patient's own blood from the lower limb into the systemic circulation, and this happens to the order of 300 ml. And this particular maneuver hasn't been affected by spontaneous breathing or heart rhythm. And because the increase in cardiac output is time limited, it has to be monitored by a real-time cardiac output monitoring device. And it has been found that this is very safe and it has a high degree of sensitivity and specificity. The other test that we can be, passive leg raising test is, of course, having its own limitations. It cannot be used in patients who have intra-abdominal hypertension, intracranial hypertension, and during surgeries and patients who have had stockings. The other test is mini fluid challenge. The normal challenge with intravenous fluids is of the order of 500 to 600 ml. 500 ml infusion of intravenous fluid into the patient by itself can become a treatment, and in patients who are in the upper part of the curve might end up going into the plateau, from wherein any further infusion of fluid might increase the hydrostatic pressure and increase the rate of complications. What has been proposed is, instead of going for conventional fluid challenge, we can use something called as mini fluid challenge, wherein the patient is given a small bolus of 100 to 150 ml over a period of 30 to 60 seconds. And since this bolus is very small, the change in cardiac output is going to happen, and if it is going to happen, it has to be observed in real time, and the threshold for this is still very limited to the order of 5%. But it's highly sensitive and highly specific, without the disadvantage of increasing the fluid as you would see in conventional fluid challenges. One another method that has been proposed apart from PLR and mini fluid challenge would be end expiratory occlusion test. This also uses the heart-lung interactions, wherein the patient's expiration is paused for a period of 12 seconds at the level of PEEP. This pause of expiration decreases intrathoracic pressure, increases preload, thereby causing an augmentation of cardiac output. Again, unlike other indices that use heart-lung interactions like PPV or SVV, end expiratory occlusion test, we do not have the necessity to use a small tidal volume. It can be used in patients with cardiac arrhythmias and in spontaneous breathing as well. The response is very small, and cardiac output monitoring has to be real time for us to have good information. So the surrogates for cardiac output is, of course, SVV, PVV through pulse contour analysis. Through echo, the most commonly used is LVOT-VTI, velocity time integral of the left ventricular output tract. And for EEO, since the change in the cardiac output is of the order of 5%, if we use something called as end inspiratory occlusion, which is stopping the inspiration for a period of 12 seconds, combined with stopping the expiration for a period of 12 seconds, gives us good threshold to the extent of 12% with VTI. Inferior vena cava, it's very commonly used because of its ease in learning, ease in using, as well as doesn't require too much of expertise to do inferior vena cava assessment. But the evidence is not so strong, because just like CVP or PAOP, the inferior vena cava volume and the walls of the inferior vena cava are influenced by other problems, like an increase in intrathoracic pressure or an increase in intra-abdominal pressure. In fact, a normal breathing might get transmitted thoraco-abdominally to have some sort of an extramural effect on the inferior vena cava, thereby bringing down its reliability as an tool for assessing fluid responsiveness. So as I'm saying here, it is like it has low reliability, reflects only the intramural pressure, doesn't take into account the extramural pressure. It cannot be used in patients who have low tidal volume in spontaneous breathing. And because of its ease of use, people start using it widely, but it is not so highly validated. The other methods that can be used for tidal volume, for fluid responsiveness would be tidal volume challenge, recruitment maneuvers, size, and Trendelenburg maneuvers. They basically try to increase the cardiac output by increasing the venous return to the heart. So I mentioned something about the parameters or the modalities or the dynamic parameters that can be used to increase cardiac output and how to assess them. The ultimate goal that has to be served by our actions is to improve tissue oxygenation. We know that we breathe oxygen from the atmosphere, it is at 21%, and by ambient atmospheric pressure and ambient temperature, by our respiratory mechanics, we try to, we reach a PaO2 of 100 millimeters of mercury at the level of the pulmonary capillaries. So from here on, if we have to calculate the arterial content of oxygen, we use this formula wherein we use hemoglobin saturation of oxygen and partial pressure. For a adult about 70 kilograms who has 5 liters of cardiac output, the arterial oxygen content is roughly around 1000 ml, 1 liter. The SVO2, that is the saturation of oxygen in the venous blood, happens to be around 70 to 75%. That means a flux of 25% to 30% happens to the peripheries. That means the returning blood has about 750 ml of oxygen, wherein 250 ml has been delivered to the tissues. So our aim by using all these maneuvers to augment cardiac output is nothing but to increase the tissue oxygenation. DO2 is, of course, can be controlled by cardiac output and the content of oxygen in the arterial blood. VO2 becomes a property of the cell itself. It also has something called as supply augmentation. But let us limit our discussion to the mitochondrial level. If the mitochondria are impaired because of certain cytokines, as in sepsis, or because of poisoning, like in cyanide poisoning, the ability of the mitochondria to use oxygen is compromised. In those cases, the VO2 is compromised by itself. In these cases, the oxygen utility is dropped and the SVO2 increases. So these are the problems which we can encounter when dealing with tissue hypoxia. If we have the capability to increase the cardiac output, if we have the capability to augment hemoglobin, we can do those things to improve tissue oxygenation. So if we are faced with a patient who might be having circulatory failure, we first have to establish circulatory failure. This is based on assessing for skin mottling, capillary refill time, increase in lactate levels, and decrease in SeVO2. We do not use conventional parameters like heart rate, BP, because those things can have a lot of confounders. Once the circulatory failure has been established, we assess for fluid responsiveness. The most commonly used, most widely applicable test that can be used for assessing fluid responsiveness would be PLR or mini fluid challenge. And if there is a positive response, if there is a drop in, there is an increase in cardiac output by these maneuvers, we go ahead and use fluid boluses. Once fluid boluses are given, we reassess the circulatory status, wherein we look for the skin mottling, CRT, lactate, and SeVO2 levels. And if it happens to improve, we continue with the same treatment. If it doesn't improve, we go back to the same pathway of establishing circulatory failure again and assessing fluid responsiveness and further fluids. One thing that we have to keep in mind is the other things that can increase fluid responsiveness or tissue oxygenation to that matter, which is augmenting cardiac output by increasing cardiac contractility. In summary, fluids can be very harmful to the patient. Finding the responder is the most important thing. And the tests that have been proven to have wide applicability are the passive leg raising test and the mini fluid challenge test. And the ultimate goal is to raise tissue oxygenation. Revising Starling's principle has helped us understand why balanced salt solutions are the fluid of choice for resuscitation in patients who have septic shock. And albumin, if colloids have to be used, is the only colloid that has been found to have any beneficial role. Thank you. I would like to take some questions. Thank you.
Sir, if it is a fluid bolus,
yeah,
whether crystalloid or colloid, which one do we prefer, sir?
We use crystalloids. We use balanced salt solutions. We know that normal saline causes hyperchloremic metabolic acidosis, and colloids have a detrimental effect on the endothelial glycocalyx. So for long-term outcomes, we use crystalloids, balanced salt solutions.
Okay. Thank you, sir. Thank you for sharing your deep insight on this goal-directed fluid therapy and Starling's laws. So a humble note to all delegates who have been joining in the Zoom platform, kindly update your name, mail ID, and registration number for TNMC registration purpose. Without any further delay, I would call upon our next speaker. Yeah.
Question.
I just like to know what is the importance of just like IVC collapsibility.
Yes, sir.
Is there a role for SVC collapsibility and right internal jugular collapsibility also in cases where you cannot do IVC collapsibility?
So people have tried SVC collapsibility to look for responses in augmentation of cardiac output. But it is not widely applicable. But there is limited evidence as to where if other parameters are not applicable, or if we are in a situation where we are not able to use those kinds of modalities, we might have some sort of information coming out from SVC collapsibility.
So it's an alternative which you can
use for
take
IVC.
it in case you are not able to measure the IVC.
Yes.
To add on, sir, for SVC collapsibility, they say like SVC collapsibility index of more than 36% is said to be fluid responsive.
Okay. Thank you.
Thank you. Thank you. So without any further delay, I call upon
I have one more doubt.
Jasin, Registrar, Department of Anaesthesiology, to share his valuable thoughts on mercurial lactate. Over to you, sir.
Hello. Video is. Okay. Good afternoon, respected consultants, seniors, and colleagues. I'm Dr. Jasin Hazarika. Before I begin, I would like to extend my sincere gratitude to the Department of Anesthesia and to CURI Hospital for giving me this platform to present today. It's truly an honor to stand before you. The topic I will be discussing is mercurial lactate. So for decades, we have been seeing it lactate as a simple sign of oxygen failure. I want to show you that this lactate is much more than that. It is a dynamic, it is a fuel, and the understanding of its movement and the mercurial nature, that's what we are saying, is what save our patients. Today, I will briefly review lactate physiology, understand why lactate rises, discuss its role in sepsis, and also talk about how we should interpret lactate in our model clinical practice. Now, the word mercurial is not exactly a standard medical textbook term. It means something that changes quickly or it is unpredictable. That is exactly what lactate is, and it is not a fixed marker with one meaning. And we will need to look at the flow of it. If we don't understand the movement of lactate, the kinetics of it, we might make a wrong decision. So today we just want to clear up that confusion. So I shall tell a story about how your understanding of lactate over the years has evolved. In the past, we thought of high lactate as an anaerobic metabolism, causing the lack of oxygen and further causing death. We treated it by just giving more oxygen and fluids. Eventually, we realized lactate is actually a fuel and a stress signal, and definitely not just a waste product. So the static number doesn't matter as much as the clearance is. So if it drops by 20% in 2 hours, the patient lives. So it is the mercurial nature is what is saving the patient. Let me take a common scenario here. A patient comes to our ER. His blood pressure is okay. His heart rate is 110, but his lactate is 4.5. So the old textbook answer would say this patient is in anaerobic failure. Give him some fluids immediately. But is he actually, or is he hypoxic? Or is his body just stressed? Now, if we treat the number alone blindly, we might just fluid overload him. We need to understand why lactate is high even before we act. The reason why we are talking about lactate today is because we check it on almost everyone. If you are in the ER, being in the OT or in the ICU, the lactate is our go-to blood test. We treat it almost like a fifth vital sign these days. And a high lactate value often creates urgency and anxiety amongst us. If we see a low blood pressure, we check a lactate. If we see a higher heart rate, we check a lactate. But the issue here is, while we are very good at measuring it, we are often very bad at interpreting it. And we have been treating the number over time. So not the physiology. The second reason why we must talk about lactate is it tells us things that blood pressure alone cannot. We have seen cryptic shock. This is our normal patient who is sitting, talking, walking, and has a normal blood pressure, but his lactate is 6. Studies like the famous trial by Janssen in 2010, it showed us that these patients have a very high risk of dying, even if we miss them. So lactate is often the cause of and the warning light we get before the patient crashes. So if we ignore it, we're going to lose the patient. Now into some physiology, our body produces lactic acid. But at our physiological pH, it almost immediately dissociates into a lactate and an hydrogen ion. So when we measure lactate on the ABG, we are measuring the stable base that circulates in the blood. It is produced by the enzyme lactate dehydrogenase, and this enzyme is the gatekeeper that is converts pyruvate into lactate. So where does it exactly come from? So it begins with glucose. Every cell in our body breaks down glucose to create energy. And this process is called glycolysis. The end result of glycolysis now is pyruvate. Now the pyruvate has two choices. Either if there is a lot of oxygen, it goes into the mitochondria to make massive amounts of energy. And if there is no oxygen or the mitochondria are full, pyruvate turns into lactate. Now it is important to know that this happens all the time. Even right now, sitting here, our red blood cells and muscles are making lactate, and it is a normal part of our lives. Under normal conditions, our body keeps the lactate level very low, like it's less than 2 millimoles per liter. And this is because our liver and kidneys are excellent cleaners. They clear the lactate as fast as we make it. When we see the level rise above 2, which we call as hyperlactemia, or if it is even above 4, which is lactic acidosis, it means there is a balance that has been broken. Either we are producing now, we are either producing too much of lactate, like in a conditions like seizure or sepsis, or we are failing to clear it, like in conditions like liver failure or cirrhosis. Our job here is to, as clinicians, is to figure out which side of the balance is broken. We often think that lactate comes from a tired muscles, but that is actually wrong. Lactate is actually produced by almost all tissues in our body, and skeletal muscle is the biggest contributor. Blood cells are interesting because they don't have mitochondria. So even the red blood cells and even our skin, they're constantly producing lactate. The intestine is also a major source of producing lactate. So if we have a patient who is having a mesenteric ischemia, we would see a massive amounts of lactate that would be pouring into the blood. So if all these organs are making lactate now, why aren't we all acidic? So that because we have something that is clearing up the systems. We call them the sinks. The liver is the main sink. It clears almost 60 to 70% of the lactate in our body, and it uses the CURI cycle to turn that waste lactate back to useful glucose. The kidneys are also handling about 30% of it, and this is why patients with liver failure or kidney failure have high lactate levels. It is not that our body is making more of it, it's just that we cannot keep up with that mess. Now, just look at the physiology of it. Traditionally, we had used the Cohen and Woods classification from 1976. They had divided lactic acidosis into type A and type B. Type A is the one where we all learned in medical school. It is caused by lack of oxygen. We can take an example of a sprinter who is running a 100-meter dash. So his muscles work hard, but the blood cannot deliver enough oxygen. So then the cells would switch to an anaerobic mode to survive. Here, the byproduct of this mode is lactate here. And then in the hospital setting, we see this in a cardiac arrest or severe bleeding. The treatment here is obvious. We would give oxygen, we would give blood and restore the flow. But now here comes the twist. In the ICU, we would often see the patients with high lactate who have normal oxygen levels. This is type B. In conditions like sepsis, or the body would release a large amounts of adrenaline or epinephrine. It forces the cells to process glucose, and then faster the mitochondria can even burn it. So the cell is not suffocating. It is actually drowning in the fuel. And now it converts the excess glucose into the lactate. So in these patients, the high lactate is a sign of stress and not a lack of oxygen. So if we just keep on blindly flooding the patients with fluids to fix the oxygen, we might actually just hurt our patients in the long run. And finally, we need to stop thinking of lactate as a toxic waste product. The new research on lactate shuttle shows us that lactate is actually a high performance fuel. So when the body is in shock, the muscles make lactate and send it to the heart and then the brain. So the heart preferably burns lactate during stress because it's an efficient source of energy. So the rise in lactate in the body that is trying to save itself, and it is an adaptive mechanism of ourselves. So we should not be afraid of the molecule. Rather than we should focus on treating the infection or the trauma that has triggered it. So when we see a high lactate, we need to know if it is a type A or the type B. So type A is what we fear the most. Conditions such as shock, bleeding, or the silent killer, which is the mesenteric ischemia. If the lactate is high and the belly is painful, we definitely would need to call a surgeon. Type B is if the patient has a seizure and suppose the lactate can go up to by almost 15, but within an hour, it will drop to normal. And if a patient has a severe liver failure, their baseline lactate would always be 2 or 3. So we have to fit the number to the patient. Sometimes we ourselves are also the culprits of the causes of the high lactate. So we also need to look at the patient's medication chart at times. The most common culprits that are the beta agonists like salbutamol and albuterol. And if we have an asthmatic patient on continuous nebulizers, the lactate would definitely go up. So this is a chemical reaction and not an organ failure. Also, we need to check for propofol as well. So if a patient has been on high dose of propofol for days and suddenly develops a high lactate and heart failure, we need to think of propofol infusion syndrome. And it is rare, but still fatal. Now, moving on to the clinical applications, this is where the mercurial nature of lactate becomes critical. So imagine I hand you a slip of paper and then it says lactate is 4. So is that patient safe or he's dying? We have no way of knowing it. Patient A might be recovering from a lactate of 8, but patient B might be crashing from a lactate of 1. The absolute number is a static trap. We cannot treat the number in this isolation now. So we have to treat the trajectory of it. So we need to know if the value is going up or is it coming down. So if the trend is what matters, then how do we measure it? Then definitely we use the lactate clearance, which is the gold standard. We will look at how much the lactate has dropped over a set time, ideally around 2 hours. The landmark study by Janssen in 2010 changed how we practice. It showed that if we aggressively resuscitate patients to clear their lactate by 20% in every 2 hours, significantly more patients survive. And if we are giving fluids and antibiotic, but the lactate isn't dropping by the 20%, our treatment isn't working yet. So we need to change our strategy at that point. And let's go to the guidelines. So to understand the 2021 sepsis guidelines, we have to understand where it actually came from. We previously followed the reverse protocol from 2001. This was called early goal-directed therapy, and it was very rigid. Every patient got a central line, and we pushed fluids and until the CVP was around 12. But then 3 massive trials called the Triology, which are the PROCESS, the ARISE, and the PROMISE trials, showed us that this rapid approach didn't actually save more lives. In fact, blindly chasing numbers often caused fluid overload. So the 2021 surviving sepsis guidelines moved away from these static numbers like CVP. They now tell us to focus on lactate normalization. The guidelines literally say we suggest guiding resuscitation to normalize lactate. And it was the shift from treating a number on a central venous pressure line to treating the actual metabolic state of the patient. So now we know lactate clearance is the gold standard, but it also has a major flaw. It is slow. Even after we fix the patient's shock and restore blood flow, it takes hours for the lactate to wash out of the tissues, and this creates a dangerous gap. We might keep flooding the patient and the fluids with the even if the lactate is still 4. And even though the patient is actually better, we need a real-time monitor and a solution. Just let us go back to the basics, the capillary refill time. By simply pressing on the fingertip or on the knee for around 10 seconds, we can assess the tissue perfusion immediately. Unlike lactate, which takes around 2 hours to change, capillary refill time changes within minutes. So if I give a fluid bolus now, the capillary refill time will improve within 10 to 15 minutes. So if I give, so it gives me an immediate feedback on whether my treatment is working or not. So why should I not look only at the lactate? So that's why I want to mention the Andromeda shock trial from 2019. They took roughly 400 septic shock patients. Half of them were treated by targeting lactate and the half were treated by using a capillary refill time. The results were quite eye-opening. So the group that was treated by using capillary refill time actually did better. They had less organ failure and a stronger trend towards better survival. Why? Because here the doctors stopped fluids earlier. They didn't chase the number, they chased the perfusion. This is why modern guidelines now suggest using capillary refill time alongside lactate as well. We must use it alongside clinical signs like using a warm peripheries or good pulse. And we need to treat the patient, not the monitor always. So this brings us to a critical warning, the dangers of lactate chase. So a patient has a lactate of 4, so we give a liter of fluid. The lactate stays at 4, so we give another liter. Suddenly, the patient is at 5 liters positive and is swollen now. This is dangerous, definitely. So when we cause fluid overload, we create tissue edema. This edema creates a physical gap between the capillary and the cells. So oxygen cannot jump across that swollen gap now. So paradoxically, by giving too much of fluid, we cause more cellular hypoxia, which creates even more lactate. And this is a vicious cycle that keeps going on. So if the lactate is not clearing after our initial boluses, we need to stop and rethink our decisions. Now we might have some few questions like, can we use venous lactate instead of arterial? ABGs are always painful. Yes, studies show that venous lactate is usually about 0.5 to 1 millimoles higher. So for clearance, venous is perfectly acceptable and it's less painful that way. I have mentioned about lactate clearance. So is there any time when lactate clearance doesn't work? Yes. So in patients with profound liver failure or kidney failure, clearance will be even slow even if we are resuscitating them. And in such cases, I would look at other markers like capillary refill time or venous oxygen saturation. And then what about Ringer's lactate? Does it raise the lactate level? This is actually a common myth now. The lactate in Ringer's is sodium lactate and it is not lactic acid. So it is actually a buffer. It does not cause acidosis. So however, if we keep on infusing massive amounts of Ringer's lactate, we might see a slight transient change in the lab values, but it is not too harmful. So as we near the end of the topic, I must warn you about the traps. Sometimes lactate lies to us. Let us look at the liver. Liver is clearing 60% of the lactate in our body. And if we have a patient with liver failure or cirrhosis, their lactate will naturally be higher because they cannot clean it up. But we need not panic. We just watch the trend for it. Secondly, let us look at some medications, drugs such as salbutamol or albuterol. They mimic adrenaline. So they pushes the cells to make lactate. And in our day-to-day practice, we have seen asthmatics on back-to-back nebulizers with a lactate of 6. Now these patients are not dying of sepsis. They are just full of salbutamol. And if we give them fluids, we might just flood their lungs. So again, we need to treat the patient and not just a number. So after all these warnings about fluid overload and false positives, we might feel, should we just stop measuring lactate or shall we just ignore it now? The answer is no. We cannot afford to ignore it because it sees things that we directly cannot. We need to understand blood pressure is often the last thing to drop. And by the time the blood pressure is low, the patient is already crashing. So lactate reveals the hidden shock. It warns us hours before the collapse begins. So we can basically, I have used an analogy of the smoke detector. So we can think of lactate like a smoke detector. And sometimes it just goes off because, we have like a burnt toast in the kitchen. So in this situation, we would never disconnect the smoke detector, right? We would definitely would like to go check the alarm and then we find the cause of the fire. So here in the same situation, if we are going to neglect lactate, we are just flying blindly. Now I'm bringing up a very practical tip for the junior doctors and nurses here. Sometimes a high lactate could also be a sampling error. So if we leave the tourniquet for too long while searching for a vein, the arm muscles run out of oxygen. So they start making lactate locally. And now we draw the blood and get a lactate of 4. But the patient is actually fine. So we need to try to get a free flowing sample without a tight tourniquet. To summarize, we shall go back to our title again. As we said, mercurial lactate. We call it mercurial because it is changeable and it is volatile. So we should not assume it's always low oxygen. It could be stress, epinephrine, or even liver issues. We do not rely on just one number. A lactate value of 4 tells us nothing. A lactate that drops from 4 to 2 tells us everything. We have to target the clearance, and if we clear it by even 20% in 2 hours, we are already saving lives. So I will leave this with this thought that lactate is just smoke and not the fire. It warns us about that something is burning, but it is our job to find out the fire and put it out. Also, I would like to conclude by saying a number on the screen should never replace a hand on the patient's pulse. Thank you so much, everyone, for your attention. And these are my references. Thank you. Thank you, sir.
I have a doubt. Can I ask
Yes.
a doubt? When we choose balance or solution, they say plasma-light, cabelite, stereofundin, and even RL also. As you said, RL is does not increase. So which is the during resuscitation, which will be the fluid of choice balance solution for according to you?
So that was the change that they happened. But later on, this point was brought out that it is not real lactic acid which is going to cause problem. So again, they went back to Ringer's lactate. And that is a very nice presentation about it. And even today, in any major trauma or any hypoxic situation, lactate is a real biomarker for assessing the situation, and treating that saves a lot of life.
Yes, sir.
Thank you.
Okay,
That's
thank
a wonderful presentation.
Thank you, sir.
Thank you. Thanks a lot. So to conclude this session, I would invite Dr. Naveen Gandhi, sir, my colleague and junior consultant from Department of Anaesthesiology, to move on to the problem-based case discussion. A case of ESRT with CAT with severe LV dysfunction with a polytrauma with fracture femur, a discussion on IV fluid strategy. To chair this session, I am blessed to invite Dr. Nagaswamy, sir, who has been the teacher for 4 decades, not only teaching us, but also preaching us and guiding us throughout the journey. He has been an examiner for DNB postgraduate students, and his videos and online lectures have helped us a lot in clearing the exams. So I am privileged to welcome you, sir. Over to you, sir.
Thank you, Dr. Shiva, for the kind introduction. Good afternoon to all the participants who have joined us for the CME. I'm Dr. Naveen Gandhi, consultant in the Department of Anesthesia and Critical Care, CURI Hospital. Video. Good afternoon to all the participants who joined us for the wonderful CME. I'm Dr. Naveen Gandhi, consultant in the Department of Anesthesia and Critical Care, CURI Hospital. I would like to specially thank our moderator, Dr. Nagaswamy sir, for chairing this session. Let me begin with the case all of us have seen often in the middle of the night. The patient with the femur fracture who arrives in the ER. The X-ray is clear. The fracture looks obvious. But what is not obvious is the pathology or the actually which determines the outcome is the physiology underneath. The patient has end-stage renal disease, coronary artery disease, and a heart which is already working at the edge of its reserve. So today, I want to focus on one question. How do we resuscitate this patient without preventing avoidable complications? Let's briefly look at the case details. This is a 64-year-old male weighing around 70 kilos. The mechanism of injury is a road traffic accident. It's a car versus bike. He was wearing an helmet, so his head got saved. But when this patient reaches us, we are not starting from zero. This is an high impact injury. So we are starting with already a deficit. We now come to the primary survey done as per ATLS guidelines. Airway is patent. Patient is speaking in full sentences. So at this point, airway is not our immediate concern. Regarding his breathing, his respiratory rate is 22 per minute. So saturation is 94% on room air, improving to 99% with oxygen.
bilateral air entry is equal. Coming to circulation, heart rate is 105 beats per minute, blood pressure is 100/65 with mildly cold peripheries. So although the primary survey appears acceptable, the number suggests the patient is compensating, not stable. Moving on to the secondary survey, 2 injuries are identified. The first and the more foremost is the right midshaft femur fracture. The thigh is tense, which immediately tells us one thing. This is a significant source of blood loss. So even though external bleeding is not obvious, the injury done can explain the tachycardia and borderline blood pressure we saw earlier. The second injury is a chest injury. It's a mild hairline crack fracture, 4th to 6th rib. There is no pulmonary condition, no signs of pneumothorax. But however, in an elderly patient with limited cardiac reserve, even the mild rib fractures matter because pain, splinting, and hypoventilation can rapidly worsen oxygen delivery. This is his past medical history, whatever we know. Is an end-stage renal disease patient on maintenance hemodialysis 3 times a week for 1 year, last 1 year. His last dialysis was 1 day prior to the injury. He's a coronary artery disease patient with a severe LV dysfunction, old myocardial infarction. Left ventricular ejection fraction is 30% is in his recent echo. He's a known hypertensive and a known diabetic. He's on correct medications of aspirin 75 mg once daily, metoprolol 25 mg twice daily, atorvastatin once daily, AC inhibitor on erythropoietin on OHA for his glycemic control. His lab investigations showed hemoglobin of 8.4, creatinine of 6.9, potassium of 5.6, lactate of 4.2. His ECG showed sinus tachycardia, old anterior MI changes. His baseline echocardiography shows dilated LV, global hyperkinesia, ejection fraction of 30%, and elevated filling pressures. Now let's step back and ask a very simple question. What actually happens in a fracture femur? First, there is massive hemorrhage. The thigh fracture, femur fracture alone can result at least 2 liters of blood loss. What happens because of this blood loss? This blood loss leads to hemorrhagic shock, causing reduced organ and tissue perfusion, rising lactate, and early metabolic acidosis, often before the blood pressure falls significantly. Second, there is severe pain. What does this pain do? Pain always triggers the sympathetic surge, which in turn increases the heart rate, vasoconstriction, and a marked increase in myocardial oxygen demand. In a patient with CAD and LV dysfunction, this sympathetic response itself can precipitate ischemia. Third, the ongoing blood loss results in anemia, which directly reduces oxygen delivery, even if the saturation looks normal. Finally, the most important thing in trauma, it initiates a systemic inflammatory response. The cytokine release leads to endothelial activation, capillary leak, and the third spacing of fluids. So paradoxically, the patient is both intravascularly depleted, but interstitially overloaded. So now let's layer one more problem onto this physiology. The patient is an end-stage renal disease patient. The first and foremost obvious issue is the reduced renal excretion of fluids. In an end-stage renal disease patient, any fluid we give remains only in the intravascular or interstitial space until it is actively removed by dialysis. Second, these patients usually have a baseline metabolic acidosis. So when hemorrhagic shock adds lactic acidosis on top of this, the margin of the physiological compensation remains very small. Third, there is always a risk of hyperkalemia, and due to the tissue injury, it increases much, and acidosis and based on its reduced renal clearance. And last, the fourth point is that end-stage renal disease is always associated with uremic platelet dysfunction. So even when coagulation parameters looks acceptable, these patients tend to bleed more, and ongoing blood losses may be underestimated. Finally, end-stage renal disease is a chronic inflammatory state. Endothelial dysfunction and capillary leak are already present. So fluids tend to leave the intravascular space quickly, worsening the tissue edema without reliably improving the perfusion. So now let's look at the most fragile component in the entire equation, the heart. The patient has coronary artery disease with left ventricular dysfunction. The first problem is fixed coronary obstruction. Because of the atherosclerotic plaque, baseline coronary flow is already near maximal. There is no coronary reserve. So usually when there is an increase in myocardial oxygen demand, the coronary arteries expand, allowing the further increase in the blood flow. But here there is no coronary reserve. There is a fixed coronary obstruction. So any increase in myocardial oxygen demand cannot be matched by increase in coronary blood flow. Secondly, these patients typically have a high left ventricular end pressure. So when we give fluids, preload rises, but does it significantly increase the stroke volume? If you see the diagram, the heart is already functioning at the flat portion of the Frank-Starling curve, as described by Dr. Satish sir. When the heart is functioning at the flat portion of the, or called the plateau of the Starling curve, so any additional preload does not increase the output. It only increases the filling pressures. So instead, left atrial pressure rises, pulmonary venous pressure rises, and the patient moves rapidly towards pulmonary edema. Third, the anemia reduces further oxygen delivery. In a heart with no reserve, anemia is not tolerated at all. And the pain, tachycardia, sepsis, inflammation, all are the parameters which can increase the myocardial oxygen demand by a significant margin. So basically, there are 4 types of shock. You know the 4 types of shock, but what really happens in our patient? Definitely hypovolemic shock because of the massive hemorrhage loss. But is it only hypovolemic shock? If we treat him like a pure hypovolemic shock and give aggressive fluids, we worsen the cardiac failure and pulmonary edema. So definitely there is another shock associated with this. So it's cardiogenic shock. But if we take away the hypovolemic part and if we treat him like a pure cardiogenic shock and avoid volume altogether, we fail to address the ongoing blood loss and tissue hypoperfusion. So the problem is not whether to resuscitate. The problem is how to resuscitate without tipping him over either edge. So at this stage, the most important step is assessment. And the first principle we need to remind ourselves is this: shock is not the same as hypotension. Shock is fundamentally inadequate tissue perfusion. Blood pressure may be still normal, especially in the elderly patient who always have a chronic hypertensive state and a strong catecholamine release. So blood pressure may be on the higher side, maybe it might be compensating, but shock, if it's inadequate tissue perfusion, shock is there. And for particularly in this patient, urine output cannot be a useful marker. So what should we always assess first? Then comes your clinical signs of perfusion. Whether the patient is confused, whether the patient is having any altered sensorium, which can suggest you that cerebral hypoperfusion is there. And capillary refill time, anything more than 3 seconds indicates poor peripheral perfusion. Cold, clammy skin points towards low cardiac output. An elevated respiratory rate is often the earliest sign of metabolic acidosis or severe pain. So to summarize, monitors can detect the hypotension, but only the clinical examination can detect the shock. So if the monitors are not reliable, then there should be some objective markers which should actually matter for you. So what objective markers can actually help you at this patient at the bedside? Lactate. The most important biochemical marker which can be useful is lactate. A lactate below 2 is reassuring. A lactate between 2 and 4 suggests hypoperfusion, even if blood pressure is preserved. More important than a single value is the trend. So as previously, the mercury lactate topic discussed by Dr. Jacinth. So you should always see about the trend. If the lactate is in a decreasing trend or increasing trend. If it's an increasing trend, so 2 hours before, what was the lactate value? Now, what is the lactate value? If it is significantly increasing, so the tissue hypoperfusion is increasing. So what you need to intervene? You need to think in that aspect. Only the trend matters, not the static values alone. Pulse oximeter. Does the pulse oximeter give you only SpO2, that is the saturation? No. It gives you more than that. Whatever it is, pleth amplitude. The pleth amplitude reflects the stroke volume. A low dampened waveform suggests low cardiac output. And apart from pleth amplitude, we can see the pleth variability. It gives us much insight into the preload dependence. So if there is a marked variation in the pleth variability, if there is a marked variation, the patient may still respond to volume. And the next thing is perfusion index. Usually in the monitor, it shows us PI, which reflects the microcirculatory flow. A rising PI suggests improving perfusion, peripheral perfusion, even before blood pressure changes. So when you give on something to the patient and you try to increase the perfusion, the first thing you can see is the saturation pulse ox showing the perfusion index increasing, even before your BP shows the increase in BP. And Beyond the markers, are there any dynamic testing? As my previous speaker clearly mentioned about static numbers can be misleading us. So dynamic testing like passive licorice test, which gives you a significant assessing of the fluid response. The main advantage of passive licorice test, you are not giving any single ml of fluid. So it is all reversible. If at all the patient tolerates the fluid challenge, the patient becomes better. If the patient is not tolerating the fluid, you can always reverse the patient and the physiology is going to nullify. But if you are giving the fluid challenge, if you're giving like a traditional method of giving a 500 ml fluid challenge, you're not in the position to take out the fluid. That 500 ml is going to cost us life. So now that we have established this patient has mixed shock, we need to answer the most important questions through series of decisions. So how are we going to make that? So we are going to use echo. So what are we going to see in the echo? So we are mainly worried about is the heart pumping. Is the patient preload responsive? So if we are going to give some fluids, will the patient's preload increase? Will the patient tolerate the fluid? Responsiveness and tolerance is two significantly different things. If the patient tolerates, the patient becomes better. If the patient is responding to the fluids and still intolerant to a certain amount of fluid, when you cross the mark, the patient becomes intolerant and the patient symptomatically worsens. Is there RV failure? Is IVC collapsible? So when we go to LV, left ventricular assessment, what do we see in left ventricular assessment? The first thing what we look at is LV, left ventricular systolic function. A quick visual estimate of ejection fraction can guide you like good, moderate, or poor. Immediately tells us the cardiogenic component. If we see in this GF what I put, there can be you can see a global hyperkinesia that confirms the reduced pump function. Meaning we must be extremely cautious with fluids and may need vasopressor or inotropic support early. Then apart from function, systolic function, you can see is LV size. The second thing is LV size. If the LV is small with kissing walls, that is true hypovolemia. This patient will likely need volume. But already if the LV looks dilated, that is a strong indicator for fluid intolerance. In a patient with end-stage renal disease, CAD and LV dysfunction, a dilated LV means extra fluid will only increase filling pressure and precipitate pulmonary edema. It will not be any way beneficial for the patient. And the next thing, what you can see in the left ventricular echoes, LVOT VTI. If it's feasible, you can obtain the LVOT. It adds tremendous value. It's in terms of you can do the VTI before giving any fluid, any assessment. So a low VTI means its low stroke volume is there. If VTI increases by more than 10% after passive licorice, the patient is fluid responsive. If it does not increase, fluid will not help and will only worsen congestion. So far, we discussed on the left ventricular echo part. So, but in trauma and shock, ignoring the right ventricle can be dangerous. So we also perform a right quick ventricular assessment. This axis view is parasternal short axis view. So what are we looking for in this view? You can see in the diagram, the septal wall is, septal flattening is there. It is called D-shaped left ventricle. Usually in the parasternal short axis view, the left ventricle has to look like a circular thing because the left ventricles are filling nicely and the right ventricle is functioning normally. It shows a circular view. But due to the right ventricular failure, now the septum is pushed towards left ventricle, look, showing you that it is kind of a D shape. This can be due to acute RV failure, pulmonary embolism, or severe pulmonary hypertension. In this situation, already the left ventricle is struggling. In fact, fluids, if you give, it will further dilate the right ventricle, push the septum further into the left ventricle, reduce LV filling, and cause a sudden drop in cardiac output. So RV assessment is very critical because a failing RV right ventricle is a strong contraindication to further fluid loading. As there was a discussion by Dr. Satish sir about the IVC, whether IVC is actually useful or not. Yes, it can be useful in some cases, but the key point is IVC alone should never be used to make fluid responsiveness. It can't be made to decide on whether we need to give the fluids or whether we should avoid fluids only based on IVC. It should always be correlated with your left ventricular size, function, right ventricular status, and the dynamic test like passive leg raise. Finally, so like heart is functioning, heart is adjusting to the fluids. So can we decide on fluids? Finally, before we decide on fluids, we must always assess the lung, because in this patient or in any critical patient, the lungs are the first organ to pay the price of your over resuscitation. If the patient is shows definitely A lines, it denotes dry lung. The horizontal, I'm not going to explain anything about the A lines or the B lines. Everybody knows about those lines. So basically, if the patient is a dry lung, lungs may still tolerate a very cautious trial of fluid, preferably a small monitored fluid bolus. But if the patient already shows a wet lung pattern, there are multiple B lines, or there are 3 or more B lines per zone, that indicates interstitial edema already. In this patient, we have crossed the fluid tolerance threshold. At that point, fluid must be stopped immediately, even if the patient looks responsive. So basically, to summarize the echo finding, what we need to know is LV decides your pumping capacity, right ventricle denotes your tolerance level, but lungs is your safety limit. So you need to remember all these 3. So, okay, so everything is sorted. You have known to assess what to assess, how to assess the patient. But whether we need to resuscitate this patient, you need to know a certain idea whether this patient needs resuscitation. For that, we need to have a evidence of tissue hypoperfusion, not just a low blood pressure. It can be already, as we discussed, it can be altered mental status, rising the trend of the lactate, cold peripheries, or signs of any poor microcirculation. Second, we must exclude non-volume causes of shock. If a shock is driven by pump failure, obstruction, or severe vasodilation, this will not fix the issue if you're just going to give fluids. It can make it actually worse. Third, we should have a way to assess fluid responsiveness. Dynamic tests already were discussed. The dynamic tests, you should be aware of those. Any increase in reduction in pleth variability suggests improvement in stroke volume. Finally, response is not alone enough. Any improvement, we must reassess tolerance, looking for lung congestion, increasing oxygen requirement, signs of RV strain, or rising filling pressure. Because you remember one thing, a positive response without tolerance is not a success, it's a warning. So once fluids have been assessed, tested, and either limited or stopped, the next step depends on why the patient is still unstable. So I've partitioned into 2 sides. The left side is a vasopressor pathway. If the patient is fluid responsive, but hypotension still persists, this is no longer a volume problem. It is a loss of vascular tone. In this situation, the drug of choice is norepinephrine because it restores perfusion pressure, improves coronary perfusion, and importantly, prevents further injudicious fluid loading. The right side, it's the inotrope pathway. It is the flow problem. If the map is acceptable, but still tissue perfusion remains very poor, the patient is cold, lactate is still rising, and cardiac output is low. Echo shows poor LV contractility, and LVOT VTI remains low despite preload. This is a flow problem, not a pressure problem. Hence, the answer is inotropic support. Dobutamine is the first choice. And if blood pressure is stable, you can go ahead with milrinone. A natural question that often comes up at this stage is, can we use colloids instead of crystalloids? If you're feeling that it is a too much crystalloid, why can't we use colloid? First, to answer that, we need to remember what actually happens to the vasculature in shock and trauma. In shock states, the endothelial glycocalyx is damaged. This leads to increased capillary permeability. So colloids, which are supposed to leak into the interstitium. And when colloids leak out, owing its high oncotic pressure, they pull water with them, resulting in worse tissue edema and pulmonary edema. And organ-specific harms are definitely going to be there with colloids. In kidney, like associated with increased need for dialysis. It interferes with your coagulation function. It increases your diagnostic coagulopathy. It has platelet dysfunction. It increases the bleeding risk. And in the lung, it extravasates to in interstitium, increases the pulmonary edema and raises the risk of ARDS. The next logical question: when do we move from fluids and vasoconstrictive support to blood transfusion? In this patient, the trigger is not a number. When do we consider transfusion when there are persistent signs of poor perfusion? This includes persistent tachycardia, hypotension recurring vasopressors, rising or non-rising lactate, metabolic acidosis, a low SiO2 and SpO2, any new ischemic changes or worsening mental status. And this patient, usually the CKD patient will have anemia. These patients might tolerate a low HB. But in this patient, the problem is this is an acute blood loss occurring in a chronic anemic patient who has no cardiac reserve. But why blood? Why can't we manage it with fluids and vasopressors? Because the important fundamental thing is fluids and vasopressors can do two things. They can increase preload and they can increase pressure. Blood, on the other hand, does something no other resuscitation fluid can. It increases the oxygen carrying capacity. It improves myocardial oxygen supply, reduces tachycardia and ischemia, and delivers more physiological benefit per milliliter than crystalloids. So we will see what blood and why. These are the what reasons. So now why? What we covered the why reasons. We could go to the what reasons. So we always use packed red blood cells because packed red blood cells improve oxygen delivery, which is the core problem in this patient. And the other components is only if indicated. FFP is added only if there is a definitive coagulopathy, and platelets if there is a definitive thrombocytopenia and ongoing bleeding. And in an end-stage renal disease patient, if in future the patient can be taken up for renal transplant, so if there is an availability of leukocyte depleted RBCs, you can always go with leukocyte depleted. So is the blood donor enough? If there is a 1 or 2 PRBCs, that's fine. Or if you go going beyond it, adjuncts are mandatorily going to be needed. So what are the mandatory adjuncts which can be used? Calcium. Because why calcium? Citrate in the transfused blood, acidosis, and end-stage renal disease can all precipitate hypocalcemia, which directly impairs myocardial contractility and coagulation. So calcium levels must be actively monitored and corrected. Temperature control. Hypothermia worsens coagulopathy, acidosis, and shock. You can call it as the triad of death. So active temperature control is always essential. Warm fluids, warm blood, and active warming devices. And you need to have acid-based monitoring. Acidosis is both a marker and driver for poor perfusion. Serial ABGs help us to track potassium management. Potassium management is very critical in end-stage renal disease. Acidosis, tissue injury, and transfusion can all precipitate life-threatening hypokalemia. Coagulation status must be reassessed continuously. Trauma, dilution, uremia, hypothermia, all increases the bleeding risk. Hemodynamic support. Hemodynamics are always dynamic. Vasopressors, ionotropes need frequent assessment guided by perfusion, echo, and lactate trends. And once you start the transfusion reaction surveillance has to be throughout. And very important thing is when you are optimizing the oxygen delivery, you're always worried about your oxygenation. If you're not dealing with your oxygenation properly, optimizing oxygen delivery is not going to be useful. So airway, ventilation, and lung status must be always reassessed continuously. And we have resuscitated with fluids, and then vasopressors, and then inotropes, and blood, and adjuncts. We all done that. Finally, what is the most important thing in resuscitation? It is knowing when to stop. Resuscitation is complete when further intervention will not meaningfully improve tissue perfusion or oxygen delivery. So there are clinical and hemodynamic signals which can clearly show you that resuscitation is enough. We can stop with the resuscitation. Those are clinically the patient is awake, appropriate mentation is there, warm peripheries, capillary fill time less than 3 seconds, no escalating respiratory distress. Hemodynamically, the patient shows a mean arterial pressure of more than 65. It can be with or without the vasopressor support. Heart rate is trending down, no increasing vasopressor requirement. The flow, adequate cardiac output is there, stroke volume is there. The fluid responsiveness, there is no further fluid responsiveness. LV filling is optimized. The right ventricle is, as far as now, guided by the echo, it is not failing. Metabolically, if you see, lactate is stable or falling. If the pH is in the acceptable range of more than 7.25, you can be like, okay. No worsening base deficit, if your hemoglobin is in the target range of 8 to 9, if your saturation is adequate, and if there is no new ischemic changes, and you can always see serial cardiac biomarkers. Anytime if there is a trop-I change, you can always try to further your resuscitation. And safety profile is very important. Always look for pulmonary edema, potassium values, and normothermia is whenever you reach normothermia. So now coming to definitive management. So what do you do in definitive management? The next goal of management is proceed to surgery once, whenever the endpoint of resuscitation, whatever the parameters we just now saw, we have reached that. So anesthetic goals will be avoiding hypertension during induction, avoiding tachycardia, maintaining coronary perfusion pressure, preserving the preload, whatever we got with the resuscitation, without overloading, preservation of AV fistula. That's a very important thing. The AV fistula is the patient's lifeline. So no BP cuff, no artery line, no IV access on that arm. For definitive fixation, we choose regional anesthesia alone. We use a combined fascia iliaca compartment block and sciatic nerve block to provide complete femoral analgesia. It covers the fascia iliaca compartment block covers the anterior thigh, femoral nerve, lateral femoral cutaneous nerve, and sometimes the arterial nerve. The sciatic nerve block addresses posterior thigh and deep periosteal pain. This combination provides surgical anesthesia without sympathetic blockade or myocardial depression. This allows us to maintain spontaneous ventilation, stable preload, and the heart rate control throughout the surgery. Intraoperatively, our focus was the dynamic monitoring. As like this all monitoring, whatever monitoring we used in the resuscitation, the same monitoring we are going to use in the intraop also. Echo-based dynamic monitoring, the patient's LVOT and VTI before and after any intervention, LV filling pattern, RV size and function, detect fluid tolerance limit, and the mini fluid balance fluid challenge based on the stroke volume and cardiac output trend. Every time when we give under ml bolus, measure the stroke volume or the cardiac response, decide stop versus continue. Continuous cardiac output monitoring if it is available, see the trend change. Trend is always more reliable than absolute values. Use alongside ELCO always. Interpret cautiously with the whenever you are using vasopressors. And the another important thing is, given this background of end-stage renal disease and limited fluid intolerance, hemofiltration or hemodiafiltration machine should always be on standby. Postoperatively, pain was controlled predominantly with regional techniques, minimizing opioids and renal safe adjuncts. You can go with paracetamol, IV, oral, it is all renal safe. Opioids can be carefully titrated, fentanyl can be used. Active metabolites of morphine is there in ESRD, is affecting end-stage renal disease, so we can avoid morphine. Any respiratory depression and hypotension should be avoided. So NSAIDs are avoided. Adjuncts can be used as such as dexmedetomidine. It is a wonderful drug used for analgesia and sympatholysis. Just monitor for bradycardia and hypotension. And the other management, other post-op monitoring is going to be your hemodynamic management. Always maintain a MAP more than 65. Avoid tachycardia, avoid hypotension. Fluid and electrolyte management. No, don't have a routine maintenance fluid chart. Replace only measured losses. Weigh the patient daily. Electrolytes should be frequently monitored. Potassium, calcium. If there is any rise, early dialysis planning is important. Respiratory care, adequate oxygenation should be there. Avoid fluid overload. Early mobilization if possible, and always ask the patient to start incentive spirometry. And cardiac protection, avoid tachycardia, maintain the coronary perfusion pressure, continue beta blockers if indicated. Monitor for any perioperative MI. Pain and anemia, hypertension are always a common triggers for ischemia. So control that, you will obviously escape from the myocardial infarction. Thromboprophylaxis, mechanical prophylaxis early. Pharmacological prophylaxis once you're comfortable, the surgeon says that hemostasis is comfortable. Dose adjustment is always needed for renal function. And you need to take care of the nutrition and metabolic care. Early enteral nutrition is very important. Avoid hypoglycemia, hyperglycemia, and maintain normothermia. So my closing line is, when physiology speaks, listen before acting. You need not hurry and do anything. So understand what the physiology is actually telling you and treat the physiology, never the monitor and the numbers. Thank you. Thank you for the wonderful opportunity.
Thank you, Naveen. That
Thank you,
was
sir.
a very wonderful, lucid presentation. I must thank God that it is a hypothetical case. If one has to face a case in real life like this, I think our BP will go up and we will be in shock rather than the patient. So this patient's fluid status, because the title today for the CME is fluid as a drug, where if we concentrate on the resuscitation part with fluids, it is a very tightrope walk. As all of you know, fracture femur, especially the shaft of femur, occult blood loss itself can be, as he said, between 1 to 2 liters. So it requires a rapid fluid challenge to restore the circulating fluid volume. At the same time, we have the handicap of the patient having an end-stage renal disease, who may be on renal replacement therapy, who cannot tolerate any rapid challenge or rapid infusion of fluids. Added to that, adding fuel to the fire, this patient also has a decreased ejection fraction and a compromised heart function. So both of them will restrict our ability to rapidly infuse fluid to replace the hypovolemic state. So it is a real tightrope walk situation where we have to use judiciously intravenous fluids. And here, because the blood is lost, not the mere fluid, plasma or other losses, we have to think of oxygen carrying capacity, because ultimately in a shock situation, it is the delivery of oxygen to the tissues which is the ultimate goal. So in that situation, your crystalloids are not going to do that job of oxygen carrying work. So it has to be only blood resuscitation to the most part. And if you give blood also, it has to be given in a slow fashion, because rapid transfusion again is going to put a load on the heart which may not be tolerated. And if you think of packed red blood cells again, which may be a more quantum of RBCs rather than added fluids along with that. Here we have to think in terms of adding immunity problem later on, if in case the patient plans to have a renal replacement in the form of transplantation, this may interfere with that. So we have to take that into consideration also. And another factor is, when there is a hypovolemic shock in these patients, there is bound to be some amount of cardiac injury also because of the ischemia. And so again, it may precipitate an ischemic attack on the myocardium. So we have to have a serial estimation of your biomarkers like troponin also in these cases to look for the presence of any acute ischemia happening in this situation. And the third thing is, we must always have access to immediate dialysis in the form of regular hemodialysis or hemofiltration whenever we use the fluids. In case we overstep and then give a little extra, we should have the facility to remove that excess fluid and maintain the volume at the correct level. And as discussed by the earlier speaker, the parameters which we have to follow for fluid responsiveness will give us a idea how much of fluid to give, and the choice of fluid apart from blood will be balanced salt solution and not the normal saline which we regularly insist on, because this patient being a ESRD patient, we don't want any hyperkalemia acutely precipitating any cardiac arrhythmias which will worsen the situation. So we have to be careful with the potassium level also. So we are having plasma light 148 without potassium available in some centers, and that will be the fluid of choice if at all you want to give a crystalloid in these patients. And the glucoside depleted PRBCs, if they are available, that will be a wonderful choice as the first fluid to resuscitate this patient. And as you give the fluid, early mobilization and early fixation of the fracture to prevent further accumulation of blood inside the thigh is a very, very important role. And for that, the safest anesthesia technique, in my opinion, will be, as he said, the combined nerve block of fascial or femoral and sciatic blocks, which will have the least hemodynamic interference in these cases. And if at all you have to go for a general anesthesia due to coagulopathy or other reasons where you don't want to go for a regional technique, then all essential monitors which will be invasive should be available. And this is a case only for a tertiary hospital with all the care available and not for a very small nursing home or a peripheral hospital. So that's my opinion about this. And anyone else having any other thought, you can share it.
Thank you. Thanks a lot for your insights, sir. Sir, with your experience, is there any role of tranexamic acid in these patients to avoid blood loss? As this patient is a known CAD,
No.
can we use tranexamic acid?
Tranexamic acid is a general drug which can be safely used, and one of the drugs which does not have anaphylactic reactions. Ketamine and tranexamic acid are supposed to be the two drugs which don't produce any anaphylaxis, so they can be safely used. And if at all you want to induce this patient, the combination of ketamine and propofol for GA will be a better choice than giving either drug alone. So the ketofol will be a better agent for induction rather than going for individual agents separately.
Thank you. Thank you. One more question. What is the role of hydrocortisone, sir? Do we have
Hydrocortisone is it's not a regular drug to be given. It is more useful in anaphylactic shock situations or patients who have already been on steroids. That will be definitely helpful. But in this sort of hypovolemic and cardiogenic shock, I don't think hydrocortisone is going to be of any help.
Thank you.
So one more question. Can we look into the option of augmenting cardiac functions?
Pardon?
Augmenting cardiac functions, like an assist devices.
Yeah, that should be available always. I forgot to mention that. That's why I said it should be done in a tertiary hospital where you have to have a support system for either left ventricular assist device or IABP should be available in the picture of patient having only 30% ejection fraction. That may be really helpful in cases where there is a further depression of the left ventricular ejection. So that will definitely help.
What would be the threshold for transfusion in these patients?
Threshold for
Transfusion, blood transfusion in those patients.
transfusion trigger, you mean?
Yes, sir.
See, in these cases, because these patients, this patient is also having ESRD, he is used to chronic anemia. So there are a lot of compensatory changes that are taking place. So nowadays, we don't see patients with 5 grams or 6 grams hemoglobin because of the availability of erythropoietin and other strategies that we follow. I have seen patients walking happily 2 flights of stairs with 3 grams of hemoglobin in my earlier days of renal transplantation. And but after the advent of erythropoietin administration and the dietary changes, nowadays all renal patients come with a hemoglobin of minimum 9 to 10 grams. And with this 9 to 10 grams, there are a lot of adaptive changes. So instead of going by the number, here the patient's clinical situation will vary. If he is going into an acute hypovolemic shock with hypoxia because of lack of RBCs, his respiratory rate compensation will go up, his heart rate compensation will go up. That clinical picture should be taken as a trigger rather than the number. Whereas you can see a patient with 6 grams with a respiratory rate of 16 or 14 and a heart rate of 80, 85 with a normal capillary refill time. That is a well compensated patient. On the contrary, if his capillary refill becomes prolonged and he becomes tachypnic, and even if he has got 8 grams of hemoglobin, don't believe that, go in for a transfusion in that situation.
Thank you, sir.
Thank you, one and all. So as we come to the conclusion of the CME session, it is my privilege to express our sincere gratitude to all those who have made this academic program meaningful and successful. We extend our heartfelt thanks to our self-esteemed speakers for their insightful and thought-provoking deliberations. We are grateful to our respected chairperson and the moderator for guiding us this session with wisdom and ensuring enriching discussion. I would like to thank all the delegates for their active participation, which added a great value to the CME. Our sincere appreciation goes to the organizing committee, the sponsors, and the hospital management, and our MS, Dr. Rupa ma'am, for their meticulous planning and seamless execution of this program. With this, we hope today's deliberation translate into a better clinical decision and improve patient outcome. Thank you all once again, and wishing you all a pleasant day ahead. Thank you.